This program is a presentation of UCTV for educational and non-commercial use only.
Okay, next it's my pleasure to introduce Joel Kramer. Joel is a professor of neurology. He is the primary neuropsychologist in the Memory and Aging group. He's an accomplished scientist. He serves as PI on several R01s and critical co-investigator on a multitude of other funded projects. And I will turn the microphone over to you.
So I'm delighted to be here. I was thrilled to be invited to give a talk here at this very exciting symposium. I actually think of this as my second chance, because the last time I spoke to an anesthesiology group was several years ago when I spoke at their very early in the morning grand rounds to talk about post-operative cognitive decline. And toward the end, when my cognitive control was clearly slipping, I made some allusion to the possibility that anesthesiology might be a causative agent in post-operative cognitive change, and I was actually hissed. Yeah. So this is my opportunity to redeem myself. All right, so cognition is really the tip of the iceberg. We've been talking about all the underlying things that are causing changes with age, but from the patient and family's point of view, it's really cognitive functioning and functional status that really are their primary concerns. So I think it's relevant to think a little bit about age-related changes in cognition. And I'd like to start off with a slide like this. This is a measure of delayed free recall, how many words from a 16-item list these subjects were able to recall after a 20-minute delay. And we took 1,000 people from the community, normal, well-functioning individuals across the age range from 16 to 89, and all we simply did here is track the number of words that were recalled after a 20-minute delay as a function of age. And as you can see, things hold steady until about our mid-30s. And then what we see is an inexorable decline with age that seems to be linear and unstoppable. And it really doesn't matter whether I do a memory slide. I could show you the exact same thing with the exact same results if I showed you a measure of executive functioning, fluency, set shifting, response inhibition, just about processing speed. I could demonstrate the same age-related decline when you look at a population sample pretty much across the board. And I think that on the one hand, this is a potentially very depressing and distressing slide when you consider the average age of department chairs and leading politicians. But I can also say with great confidence that that impression would be really quite wrong, because this is a cross-sectional, population-based finding. And what I think is much more likely to happen when you follow people longitudinally is that you get some variability in how individuals age. And this really is the central scientific topic for aging research, not what happens to us as a population, but what are the factors that underlie change in an individual. And this is real data on a measure of executive functioning that was done longitudinally. And as you can see here, there are a handful of subjects who actually got better scores on follow-up evaluation, although most of them showed some small decline. The important point here is you get variability in cognition with age. So some people can do it healthily, some people are not doing quite so well. So the primary goals for me today are to review some of the characteristics and mechanisms of cognitive aging, and then talk a little bit about what the role neuropsychological assessment might play in studies of typical aging or pathological aging. Now, Bruce alluded to it earlier, but there's a very implicit assumption that underlies my entire talk, which is there's no such thing as normal aging. It gets rid of the term normal. Aging is Cognitive aging is an aggregate of a whole host of factors, many of which are pathologically and many of which are age-related. But there's really nothing normal about it. And the important thing about this kind of assumption is that when we take this approach, we can now start to think about ways of improving the way in which we age cognitively. That cognitive decline is not inevitable by any stretch. So let's start with a general model of cognitive aging. It's pretty basic. You've got cognition down here. And my basic operating assumption that I think we all share is that cognition is mediated by brain structure and brain function. So now the question is, what are some of the factors that influence brain structure and functioning? So as we age, there are a host of factors that are involved in influencing brain structure and function that in many respects are part and parcel of aging. We've got vascular changes, synaptic metabolism, that changes with age, histone synthesis, hormones. I don't have slides to show you today, but you can definitely see a downward trajectory for things like testosterone as men age, and testosterone is associated with spatial cognition. So again, one other influence on cognitive aging. Protein aggregation. These are the neurodegenerative diseases that Bruce and Bill Seeley talked about very eloquently. Dendritic spine density, glucose utilization, and Christine will talk about some other factors related to glucose metabolism, I suspect, later on. So you've got all these things that are influencing brain structure and function, and again, many of them are remedial. So if you take a neuropsychological approach to trying to understand these multiple and interacting factors, I think one of the things that's useful to do is to target some very specific mechanisms of cognitive aging. There are multiple different mechanisms up there, some of which are more important than others. And so I think it's important to think about what brain changes or what structural and functional changes are associated with some of these age-related mechanisms. Think about the underlying impact on the brain, and then try and identify those cognitive functions that are most associated with those regions or networks to target for both, let's say like a pre-surgical evaluation or to follow people longitudinally. All right, so let's go back to our model, because I wanted to talk a little bit about what I think are the three most salient phenomenon that impact the way in which we age cognitively. So again, protein aggregation is a big one. We've got a whole host of abnormal proteins causing a whole host of neurodegenerative diseases. And probably the most important for our purposes here is Alzheimer's disease. And just a brief comment about this. So we now know that about a quarter of the older normally functioning community-dwelling individuals are known to have amyloid deposition on autopsy. Bruce mentioned that easily 20 to 25% of apparently normal individuals in the older age ranges are PIB positive. We're beginning to see more and more data that suggests that being PIB positive is not a benign phenomenon, that it's been associated with smaller hippocampi, it's associated with poorer memory performance. So I think one more reason why having compounds like PIB or AVID as a pre-surgical technique to identify people at risk for ultimate neurodegenerative disease is both scientifically and clinically very, very important. How about neuroinflammation? And again, this is something that people with a lot more expertise will be talking about a lot later on this afternoon. Importantly, neuroinflammation is directly associated with the tendency to aggregate abnormal proteins as well as vascular changes. And we now know that even peripheral injury can be associated with neuroinflammation. And we're beginning to understand now some of the mechanisms of neuroinflammation that impact cognition. So the microglia put out a lot of interleukin-1 in the hippocampus following even a peripheral insult. And again, every time I see Mervyn at the gym and we're thinking about all the orthopedic injuries that we're getting, I'm thinking, you know, what impact is this having on our IL-1 in our hippocampus? And these elevated levels of IL-1 in the hippocampus is associated with disruption in long-term potentiation, which is a major part of neuroplasticity and memory formation. So again, if you know, in young folks, and you know, this elevation in neuroinflammatory cytokines is very time limited. In older animals, presumably humans as well, this elevation in inflammatory cytokines is more sustained and much more likely to interfere with brain structure and functioning. So what is it? So we've got two types of disorders here that are interfering with medial temporal systems. We've got abnormal protein aggregation in the form of amyloid, early Alzheimer's disease, and inflammation may in fact impact the medial temporal function and memory formation. So what are the medial temporal lobes doing? Well, again, with the help of long-term potentiation, the hippocampus is critical for forming long-term memories by way of creating these presumably cortical neural circuits that at some point can function independently of the hippocampus, but are dependent on the hippocampus for their initial formation. And these are the underlying neural representation of our episodic memories. So what happens in our patient groups, the ones who have some medial temporal pathology? Well, when you give patients with, say, Alzheimer's disease or any other neurodegenerative disease, and I've got progressive nuclear palsy up here, but it could be Lewy body, it could be frontotemporal dementia. If you give them a list of words to remember, and this is a 9-item list, and you give them 4 learning trials, you really may not see very many differences between those patient groups. They're doing less well than controls, but at this point, their memory performance is indistinguishable. What happens when you have some hippocampal pathology or medial temporal pathology for whatever cause, whether it be hippocampal sclerosis or tangles or potentially elevated interleukin levels, what you start to see is a failure to consolidate information, which becomes increasingly evident even over a delay as short as 10 minutes. So this is the neurocognitive signature of medial temporal pathology. And importantly, if you're evaluating patients in clinic, you may not always get dramatic impairment after 10 minutes, particularly if it's one of your normal community-dwelling elderly who's being seen for a pre-surgical evaluation. But we now know from patients with some hippocampal leptiform activity is that even if you don't see any changes after a 30-minute delay, if you wait 1 week or 3 weeks, you really start to see the deficits emerge. So again, I think the importance of very carefully evaluating our pre-surgical candidates if they are shown to be at some biomarker or biological risk for neurodegenerative disease. Just to illustrate the point that these regions are very specifically associated with this capacity to take on new information and hold it and consolidate it for later. We've did a study where we had the hippocampal volumes, cortical gray matter, the entire cortex, as well as a measure of white matter signal hyperintensity, and basically showed that when you looked at immediate memory, and this is those learning trials that didn't dissociate between progressive supranuclear palsy and Alzheimer's disease, the best predictor of how well someone does on a task like that is overall cortical integrity. But if you look at how well they did after a delay, even after controlling for immediate recall, here you now see the very specific association between hippocampal volumes and this capacity to consolidate information over a delay. All right, so I want to spend the rest of my time talking about vascular changes, because I think vascular changes are huge. Bill alluded to vascular changes earlier. And I lump together here not only identifiable vascular changes in the brain, but the whole host of cerebrovascular risk factors, including and I'm sure Christine will be talking a lot about these, and I'm not going to steal any of her thunder, other than this is a very, very broad category of factors that impact brain structure and function. I think Bruce made reference to silent lacunes that are present in a good 25% of normal elderly who come in for a research MRI scan. And this slide is to simply point out that these silent lacunes are not silent, that these were high-functioning, community-dwelling elderly who are cognitively intact. And yet, when you looked at it, when you very carefully measured their executive functioning, you could see a linear relationship between the number of these so-called silent lacunes and how well they did on an executive measure. So these infarcts are clearly having a negative consequence for cognition. Now, most of our folks don't have lacunes. What they have are far more subtle changes to the white matter. And there are a couple of MRI markers of age-associated white matter changes that I think are worthwhile pointing out. The first is what we've been used to thinking about for all these years, which are these white matter signal hyperintensities, typically in the sort of paraventricular regions that Bruce alluded to, and then a newer technique called diffusion tensor imaging that looks at, and again, Bill talked about this, to look at the microscopic integrity of white matter. Does white matter change with age? Absolutely. This is data from the Framingham study, which looks at the number of white matter signal hyperintensities across age, and certainly there's a fairly steady and possibly a slight increase with once you get past the age of 70. And with this newer technique that I mentioned, the diffusion tensor imaging, fractional anisotropy is really the measure of the fiber tracts. Basically, you want, water tends to diffuse quite broadly. If they're in a fiber tract, they're only going to diffuse along the length of the fiber. So this is anisotropic. You want a lot of fractional anisotropy on your diffusion tensor imaging, and what you can see is decreasing FA with age. What's the impact of these white matter changes? Well, a major consequence of white matter change in the brain is a reduction in information processing speed. The white matter is what connects everything together. It's the transmission lines. So information processing speed may be one of the most subtle or most sensitive markers of underlying white matter changes. And of course, what are some of the consequences of cognitive slowing? Well, you have downstream effects on attention, downstream effects on working memory, and in particular, executive functioning. I can't really stress that enough. Executive functioning is a general term that refers to our ability to inhibit inappropriate or irrelevant responses, focus our attention, generate novel responses, think flexibly, so it's a very, very key thing to measure. Another important aspect of executive functioning is that we think of it as being at least in part mediated by the frontal lobes. And we now know that white matter disease in just about any part of the brain is associated with frontal hypometabolism. So that white matter changes can have both direct and indirect effects on executive functioning. So how do we measure information processing speed? We want to do it as simply as possible. So we've been studying a couple of hundred normals. We'll be following them longitudinally with imaging. And one of the things we wanted to do was look at how quickly they could make very, very simple decisions. These are tasks that, do these two words rhyme? Do these two words rhyme? Everyone gets them all right. And the question is, how quickly can you make those decisions? Another one, again, everyone's going to be able to figure out which of these two dots is closest to the one in the center. Not rocket science. What we're really looking at here is how quickly you can make those decisions. We use a range of tasks like this, because the more tasks you have, the more reliable your measure. We can compare, there are several different ways of generating a composite information processing speed score. Importantly, these scores are not picking up motor speed, they're not picking up perceptual speed. What they're designed to do is pick up central information processing speed. Do we see changes with age? Absolutely. And we also see some interesting associations with diffusion tensor imaging. So this is a study that was done by Jeff Kirshner, who was in our group and got lured to Stanford. So we had 131 subjects who were squeaky clean cognitively. You know, we talk to their informants, we give them a neurological exam, we give them cognitive testing. These folks are genuinely cognitively normal with no hints of any neurodegenerative disease, no declines over the last year. They're about 70 years old and, not surprisingly, a fairly high mini mental state exam. Jeff looked at sort of a more global look at fractional anisotropy. In red, you can see the white matter in the brain, and down below, and I don't know how well you can see it, but the areas in red are those areas of the white matter that were directly correlated with these subjects' performance on the information processing speed tasks. You know, a couple of the other things that Jeff did to explore the data a little bit further was to also show that most of these same regions are the ones that show changes with age. And if you create a mediational model and say, well, why does information processing speed change with age? If you put in the changes in the white matter as the mediating factor, that seems to explain most of the age-related changes. In other words, as we age, we get slower, not because we're getting older, because we are accumulating some injury to our underlying white matter, and clearly this is something that can be prevented. For the sake of time, I will just really highlight the one point, which is when you're designing measures of cognition for studies of long-term change associated with say, surgery, you certainly want to be able to have measures that have documented sensitivity over time, and just to emphasize that, you know, we certainly have measures that are sensitive, memory measures that are sensitive to hippocampal change over a 4-year period, and we have executive measures that are sensitive to white matter changes over a 4-year period. So basically, to conclude, I think that age-associated cognitive decline is driven by a multitude of interactive factors, most of which I think are pretty pathologically, but importantly, many of which are very amenable to intervention. And you know, because models of how peripheral trauma impact cognitive aging will help us, I think, continue to identify what the key anatomical regions and networks are that are at risk with peripheral trauma like surgery. And I think neuropsychology would be thrilled to collaborate with the imaging and biological expertise in this room to learn a little bit more about not only what the impact of peripheral trauma is, but how to ameliorate it. Thank you.